doing the presentation of Deyo Charlson's index for HAP 464 at GMU for the semester of spring 2021. So this is the history of the diagnosis-based prognostic indexes. So in 1987, Charlson's core morbidity index was first developed by Mary Charlson and colleagues. Its original purpose was to predict risk of death within groups of patients, for example, hospital patients or a large group of individuals in a year. In 1992, so in about 5 years later, the Deyo Charlson Index was adapted by Richard Deyo and colleagues. So this purpose was to focus on more of the predicting long-term survival, as well as the Romano's Charlson's Index was also adapted at the time, the next year. And then in 2000 and later on, cancer-specific NCI comorbidity index were developed by Carrie Clambund, and this was basically so that these indexes were able to be more specific to certain diagnoses and be more accurate. So the Charlson's index again was to determine mortality rates in hospitals. An example of this was in the 2020 Care Register for Healthcare, or HILMO. This basically was a trial or research that ensured the accuracy of the Charlson's index, and the results were that it was pretty still accurate with some miscounts here and there. In the Deyo Charlson's index, it predicts long-term survival. So an example of this was in the 2018 cardiac condition patients. And so for this, we were able to determine the survival rates of specific diagnoses. So for cardiac conditioned patients, and that actually turned out to be insanely accurate and is probably the most used index. And then we have the Romano-Charlson's index, which was the creation of ICD-9 codes. An example of this was the 2017 cancer patient ICD-9 codes, and basically what it did was it took many patients that had the same diagnosis, in this case cancer patients, and we were able to make ICD-9 codes out of that and determine the accuracy of it. And so presenting the data, we were given 4 sets of data, and so the total amount of patients after combining all of them together was about 30 million patients. As you can see here in the video, there are a lot of patients that were put into here. And so because, as you saw, that there were a bunch of nulls, we had to clean the patient data, meaning that there were no zombies, which were age of diagnosis that were greater than the age of death, meaning that they were diagnosed after they died, which doesn't make sense at all. And then we had to take out the ghosts, which were patients with no visits but were still on there. That didn't make any sense. And any miscellaneous items, including removing the nulls. So with this, we were able to clean out a lot of the data that was either incorrect or unhelpful to us. And so after that, the numbers of records used in the analysis was about 17 million patients. And for us to continue, we all had to have the same amount of clean patients. And so next we did the index scoring. And so the importance of scoring is to determine the mortality rate and interprets the significance of the diagnosis. So each patient was diagnosed with the diagnosis, and for that we were able to create a score for them using the Charlson's index, or the Deyo Charlson's index. And so next we were able to calculate the accuracy of the index. So this was the graph that we were able to create with the data found on in the patient data. And so the closer the curve, which was the orange line, the sensitivity, and 1 minus specificity, is to the dashed line, which is just the sensitivity, the less accurate the data is. So in this case, it wasn't too bad. It was pretty accurate. Recommendations to improve the accuracy of the index. So updating the index on a constant basis is very important. Since the index was originally made in 1982, not all the diagnoses are as common as they are now in 2021. So updating the score weight of each diagnosis would be very important, since there are different ways to treat different conditions now compared to back then, and updating the diagnosis type. Thank you so much.